Hello, good evening, everyone. Welcome back to my IVF Answers. This is our second event this week, and I'm really happy to be back here with Dr. Kristýna, who has joined us today. This is your second webinar with us as well, so lovely to have you back. We already discussed this beforehand. I know that you had a chance to enjoy your summer, and now you are busy at the clinic, of course, but I'm glad that you agreed to simply join us today and talk about implantation failure, as this is our topic. How are you? Good to have you.
Yes, thank you. Thanks a lot for the introduction. I'm fine and I'm eager to start because it's quite an interesting topic and there's a lot to discuss about the implantation failure.
Definitely.
Still, to start with, the implantation failure is still a big black box because there's lots of things that we still don't know and they will emerge later on, hopefully, and we will be able to
some things are still
give you some better insights on
Definitely. Okay, thank you so much. We will start. Just let me remind everyone, whoever hasn't been here before. We will start with the presentation on our topic. It will take up approximately 20 up to 30 minutes, but afterwards, as always, there will be time for your questions. So all you need to do is just type those in the chat, and Dr. Kristýna will definitely answer them for you. We will have around 30 minutes for the questions, so you can type them during the presentation or afterwards. And of course, remember, it's all anonymous. It's being recorded as well. And before we start with the presentation, let me just properly introduce Dr. Kristýna Frühaufová from GYNEM Clinic. She's the head physician at GYNEM Clinic located in Prague, in Czech Republic. And now we will go ahead with the presentation. Yes?
Okay.
Brilliant. Again. Thank you so much then. Let's go for it.
Okay. So I'm going to talk about the implantation failure. As I said, it's a lot big ground to cover. So let me just start briefly. We know that the implantation, of course, is a crucial step in human or in overall reproduction. It requires a synchrony between the embryo and the endometrium. There are lots of aspects that play a role in the successful implantation. One of them, of course, being the embryo genetics. The embryo has to be chromosomally correct in order to be able to open the dialogue between itself and the endometrium. There also has to be, there shouldn't be any distortion in the anatomical factors. Also, the endocrine and immunological factors play a role, and we shouldn't leave the microbiome out of the topic. What we have to keep in mind is that each cycle and each embryo is unique. So even if you do repeated transfers, you don't have the same conditions. You don't have the same hormonal conditions. You don't have the same genetic makeup of the embryo. And with that, you get a different immunological response from the woman's body. So when we look at the topic of the implantation failure, based on the data we have, we know that even if we are transferring an euploid embryo that has been previously tested, up to 35% of those embryos don't implant for the first attempt. If we do repeated transfers, the cumulative implantation rate of 3 single euploid embryo transfers is up to 95%, which leaves us with about 5% of women who really have the repeated implantation failure. Up to now, we don't have clear definition what repeated implantation failure stands for, actually. But in the reproductive society, we tend to call it the inability to achieve implantation after 3 and more attempts of transfer of euploid embryos, or the equivalent number of unscreened embryos adjusted to maternal age, which means that in younger women, we know that we need less embryos to achieve pregnancy than, for example, in women over the age of 40. And one of the important aspects to keep in mind is also the normal endometrium that is thick enough and doesn't have any anatomical abnormality. One of the factors that we have to look at is, I called it the maternal age, but now we are speaking about the age of the oocytes, basically. We know that the oocyte quality decreases with age. That's a fact that even with the assisted reproduction techniques, we cannot beat. So we know that the rate of aneuploidity in embryos increases with the age of woman. The highest chances to have a chromosomally normal embryo is at the age between 26 to 35 years of age. In women after the age of 35, we see approximately 40% of embryos being abnormal, and this rate of abnormality or aneuploidy goes up to 70-80% in women after the age of 43. So around the age of 35 to 40, let's say you have every second embryo that is euploid. If you reach over the age of 40, then this rate becomes much higher in towards the aneuploidity. So, for example, in women at the age of 45, we know that statistically each seventh or eighth embryo is normal, and the remaining embryos carry some chromosomal abnormalities. The immune system plays a crucial role in the implantation process. The implantation, we have to look at it as an active process because it's not that we put the embryo in and it will stick. It's basically a crosstalk between the embryo and the endometrium. If you imagine the embryo has some information that it presents itself to the woman's immune system, and the immune system has to read this kind of information in order to be able to accept the embryo. So we get two possible response of the immune system. Either the embryo is opening the discussion, so it's an activating or inhibitory response on the other hand. So basically, the dialogue between the embryo and the endometrium that is mediated through the immune system is the crucial step to the implantation. Before we do the embryo transfer, we should look at the anatomy of the small pelvis, which is usually the basic part of each examination even before the planning of the IVF cycle. So we know that the presence of, for example, polyps or submucous fibroids or septum or adhesion may reduce the chances for implantation. Also, the presence of the hydrosalpinx may reduce the chances for pregnancy up to 1/3. It's mainly the fluid that is present within the hydrosalpinx that may actually flush out the embryo and also is creating hostile environment for the embryo implantation. There are several other hormonally dependent diseases, for example, the adenomyosis or endometriosis that play also or cause hormonal disbalance, which may give you reduced chances for implantation. So those are the diseases that we also look for when we have repeated failures. We should also consider or keep in mind the lifestyle factors. We know that the body weight can have adverse impact on implantation. We know that both sides of the spectrum, either the underweight or the obesity, is associated with poor reproductive outcomes. So generally, patients are advised to maintain the healthy BMI between 19 to 25. If the patient is obese, again, we have done some distortion in the hormonal or production or hormonal disbalance, which may affect the way that the body is producing the hormone and might actually shift the implantation window and might reduce the production of progesterone. We also know that, for example, smoking has a negative impact on both the oocyte and the sperm quality. So patients are advised to stop smoking even before planning the IVF cycle. Also, excessive alcohol intake might negatively impact implantation and pregnancy, and high levels of stress causing the production of the stress hormones also have negative impact on the infertility treatment. What has been investigated quite thoroughly in the past year is the microbiome. Now we know that the uterine cavity is not sterile. It contains lots of not only bacteria, but it is an open system, so it communicates with the vagina. But we know that there are different bacteria that should be dominant within the uterine cavity. So we know that the lactobacillus dominant composition within the uterine cavity seems to be favorable for implantation. If there is dysbiosis, which means that there are some bacteria present that may cause chronic inflammation, with this, the patients might be prone to have implantation failure. Another important factor is the progesterone supplementation in the second phase of the cycle. We know that, especially in patients that have the fully supplemented cycle for embryo transfer, maintaining sufficient progesterone levels is crucial. In Europe, we mainly use the vaginal progesterone. In patients with repeated failures, we check the progesterone levels on the day of the embryo transfer. If the level is insufficient, we usually use the combination of vaginal and subcutaneous progesterone. So it's better to use those two ways of progesterone because it ensures that there's better absorption of progesterone. We know from the studies that even the sperm quality might have adverse impact on the implantation, especially the semen with high fragmentation rates may contribute to low implantation failure. On the other hand, the overall lower semen quality may lead to early or early miscarriage. So, what are the general recommendations if we have patients with several attempts of good quality embryo transfers and still achieving no pregnancy? So first of all, to look at the possible anatomical causes for infertility, and if we see any, then to treat them. The most demanding is the role of adenomyosis, which is sometimes difficult to treat, and the adenomyosis usually requires long preparation prior to cryoembryo transfer with like long-term downregulation in order to cut the excessive production of estrogens. Also in patients with repeated failures when the embryos haven't been tested previously, we recommend doing genetic testing to the embryos to make sure that the embryos that we are transferring are genetically correct. The DXC method is generally recommended for lower semen quality. If we have patients with a diagnosis of chronic inflammation, then usually doing the round of antibiotics prior to embryo transfer might be beneficial for the patient. However, if we look at the other medication that is usually added to the cycle, there is no proof of the wide use of those kind of medications. For example, glucocorticosteroid or even the immunomodulatory drugs such as the immunoglobulins or so in the overall number of patients, if we get to all patients, it's not beneficial. It's only used in selected patients with well-defined immunological disorder. There is no magical medication, magical drug that it's working for everyone. So if it does work for someone, it doesn't have to work for your friend. So we always have to be very cautious, and we always have to search for the possible cause of the implantation failure. Doing the endometrial scratching, which has been quite popular in the past, let's say 10 years, has no proven efficacy, so it's no longer used. Also, the use of immunoglobulins, PRP, or the ACG in the uterine cavity has a lack of evidence. So we still don't have enough proof to say that this treatment is working properly. We still need bigger numbers and bigger studies to prove the efficacy of this kind of treatment. So to conclude, the true implantation failure is quite rare. It's about 5% of patients that really fall within this category. And we have to be cautious about what we call an implantation failure, because first of all, we have to look at the embryos themselves. We should be sure that the embryos that are failing to implant are at good quality in both, let's say, the genetics and the morphological quality. The implantation, as I said before, is a dialogue between the endometrium and the embryo. So if you imagine it as the embryo carrying some kind of information on its surface, that this kind of information has to be comprehensible to the endometrium. So the immune system within the womb should be able to read this kind of information, and if it makes sense to it, then to accept the embryo. So, but we know that this kind of antigenes, the information on the surface of the embryo, is a combination of unique conditions that combine the egg and the sperm. So each embryo is different. Each embryo will be talking to the endometrium in a different way. So even if you have the same morphological quality of the embryo, still the endometrium might respond differently to different embryos with different antigenes. We know that each failed attempt is exhausting for the patients, both emotionally, of course, financially. But as I said, we should keep in mind that even with doing the repeated embryo transfer, we have different conditions. So with each attempt, we do have a new chance that this will end up successfully. The cumulative pregnancy rate over 3 transfers of euploid embryos is up to 95%. So if you do have 3 attempts, you do have a fair chance of achieving pregnancy. That's all from me, so thank you, and we can move on to the questions.
Thank you so much indeed, Dr. Kristýna, for this presentation, for walking us through all aspects, I guess. But of course, now we will go for your questions, and I know that some of you have really detailed questions already. So let's get back. Let's get to those. As you can see, lots of questions are coming in. So we still have enough time, I believe, to answer. We have around 40 minutes for those. Okay, so let's get going.
Okay.
With the first question that we have, let me just go here. So what is the role of lining thickness on the implantation?
Yes, I didn't cover this because it's a tricky question to answer. The lining itself, the thickness, is not well defined. What is the minimal thickness? We usually consider anything above 7 millimeters to be okay for to plan the embryo transfer. We were speaking about the thickness of the endometrium in the first phase of a cycle, because when we add the progesterone, the endometrium changes its both the pattern and the thickness. And what is also crucial is the way that the endometrium looks, because we should get a well-defined triple lining to the endometrium. So still there are debates whether it's the looks or the, the height or thickness of the endometrium that is more important. And still there's no consensus even within the IVF society. So it's both those aspects. And also you have to look at the history of the patient itself, because there are some women to grow thinner endometrium and even get pregnant with 6 millimeters. So if we know that the patient has had successful pregnancy with a thin endometrium and you're using quite high doses of medication, there's no need to cancel the cycle just because the endometrium is thin again. So yeah.
Okay, thank you. And while we are on thin lining, etc., there is another question on this. So I will go back to the previous questions and let me show you this. So is thin lining always a cause of implantation failure? Some people have been able to achieve implantation even with lining less than 6 millimeters.
Yes, that's what I said exactly. We have to take the patient into consideration, the history of the patient. You know, when you have really thin lining and the patient is not responsive to the medication, the first thing before actually doing the embryo transfer, from my expertise, is better to look inside the womb to do the hysteroscopy, because when the lining is really thin and it doesn't develop the nice pattern, you want to rule out any adhesions before you actually do the embryo transfer. But if you're sure that the cavity is fine, then we've seen pregnancies. It does reduce the chance a bit, because you need the endometrium in order to have sufficient placentation. Actually, the patient might be at higher risk of having preeclampsia or any other pregnancy-related complications later on.
Okay, and again, someone added, so what's the upper limit for lining? Thickness, sorry, thin lining, right?
Well, again, depending on the pattern, we don't usually transfer or plan the transfer when the endometrium is above 13 or 14 millimeters. But again, I've seen patients having nice and really thick endometrium within the natural cycles and always had this kind of lining. So we know that it's their pattern, so we have to follow it.
Of course. Yeah. Thank you so much for those questions already. And now we will go to another question from Catherine. What drives the embryo becoming abnormal as we age?
It's also a difficult question. It's mainly, we know that most of the abnormalities come from the egg. We, as women, are born with some number of the eggs that just age with us. That's one of the factors. So we are not creating new ones. The DNA within the egg is quite unstable due to being put on hold within the division process. And there are some protective matters, protective protein that sort of cover the DNA, but those wear out over the aging process. So you have all the, the impacts from the outside world, all the free radicals that are sort of bombing our bodies all the time. And if those protective factors are not working properly, then you're prone to have DNA damage. So this is one of the factors why with the aging process, the damage of the DNA becomes more and more frequent. And later on, during the fertilization, this will turn into abnormal embryo.
Okay, thank you so much
So
for yet
still,
another question. Of course.
unfortunately, nothing we can do about it.
Unfortunately, this is the case here as well. So we just need to. We cannot change that. This is the only problem, right?
Yes.
Okay.
And
Yeah.
yeah. Sorry. What I wanted to say is that all this damage adds up. So if you decide to have children after the age of 40, you're dealing with some damage that you've done in your 20s. So there is no way to reverse the time. And yeah.
This is the main issue, I think, right?
Yeah,
So this is the thing.
unfortunately.
That's why whenever we have a webinar, we always talk about age. That's the reality. That's number one thing, I think, right?
Yes, exactly. Yeah.
All right, let me have a look at the next question. So how safe IG to 8 implantation?
Well, still, we are dealing with lack of data. We know that it shouldn't do any harm, but we are not sure whether it has any effect or positive effect to the implantation. So, yeah.
Okay.
We don't know if any medication that we actually add to the cycle and it doesn't have any proven effect might be potentially harmful. So you might have any adverse reaction to any kind of medication. So we should be always cautious about, adding something blindly to the cycle just to see. And also what is important that, as I said, each embryo, each attempt is different. So it's like, imagine that you're flipping a coin. So still you have so many factors that play a role in the implantation. So even if you add the medication, the question is whether it really helped or it was just luck that it worked out, and it would have worked out even without it. So still, you're taking the chances and waiting for the result.
Okay, thank you so much for yet another answer here. Okay, so why polyps come back to me after I removed them 6 months ago? What causes them to grow?
Most likely, we don't know. We don't know. There are women that are prone to have repeated polyps and they have to undergo repeated hysteroscopy and polyp removals. It is most likely some benign mutation to the cell within the endometrium that's causing the endometrium to overgrow on one spot and cause the polyp. So most likely genetics.
Yeah, okay. Thank you
The same
again.
with fibroids.
So it's more like because of genetics most of the time. So it's something
yes,
that,
yes.
yeah, again, it runs in, yeah, I mean, that's the case here.
Yeah.
Okay, thank you. Now I will show it to you because there's a longer question here. What role does male factor play, especially high DNA fragmentation? 12% would be normal range. We have 20% fragmentation, tunnel method. I am 39, my husband 48. All the results are great. AMH 2.50, ICSI in the Czech Republic of 5 blastocysts, 2 were healthy. Those who were examined for PGTA, I think, did not become, I'm not sure here, pregnant, but those who were not did but lost it in 7 weeks. Hysteroscopy already done, immunology too, but first do for transfers, anything you can recommend?
Well, as I said, the DNA fragmentation, but 20% is not that high. So it may play the role in the implantation failure because the sperm is equally important in the fertilization. We know that it usually doesn't carry that much of the percentage of the chromosomal abnormality, or doesn't add that much of the percentage of chromosomal abnormalities to the embryo than the egg. It's usually the egg to blame, but still, you had the embryos tested, so you know that those that have been transferred are genetically fine. As I said, it's the way that the embryo has to present to the womb. So these are the care genes that have been studied over the last years, and it seems that there are some women that are less prone to get pregnant. This is sort of some kind of immunological phenotype, as for example, some people tend to get ill anytime they meet someone who is ill, and some people are more resistant. This applies also to the matters of implantation. So we know that some women are lucky enough to get pregnant on each attempt, and some of them are less lucky and they need really specific embryo with specific antigens to be able to open the dialogue and to make the endometrium accept it. So we know that in this women, statistically, it takes more attempts even if we are transferring euploid embryos.
Okay, again, crystal clear, I think. Thank you so much. Now has another question here. So I have a septate uterus and had four failed IVFs. I did the ERA test and this was a normal. It came back normal, but shows I don't have any good or bad bacteria present and no chronic infection. What do you suggest?
Well, you had you mentioned the septum, and the septum was removed, or yes, it's a septic uterus. Again, the septic uterus, if it's like, depending if the uterus, I understand the septum being like the parting the uterus, so if it can be dealt with like doing hysteroscopy, then the septum should be removed prior to the attempts, because we know that it's anatomical distortion. Even if the uterus is ill-shaped, it might be reconstructed using both like hysteroscopy and laparoscopy. It depends on the way that the uterus, the cavity, is affected by the septum, so depends on the depth of the septum itself. So the septum might be the cause of the failures themselves. Concerning the microbiome, as I said, what we know is that the lactobacilli dominant environment should be more friendly to the embryos, but on the other hand, even healthy women with lower percentage of lactobacilli get pregnant. So it's really difficult to find out what is the proper environment, the proper microbiome within the uterine cavity, because you have to test healthy women that have had previous pregnancies, and you have to test the microbiome on the second phase of the cycle, because the microbiome most likely changes during the menstrual cycle. So you want to see the conditions in order to set up the proper environment, and you have to have sufficient samples, or sufficient number of women undergoing the testing. So what we can define right now is to say, okay, if you're lactobacilli dominant, you're most likely to get pregnant. But still, if you have less lactobacilli, it does reduce the chances, but it doesn't mean that you don't stand any chance at all. So again, we need to do some more research on this topic to see what is right. And most likely this is unique for each of us. And the microbiome also keeps on changing all the time, depending on our diet and our habits.
Let's
And
make it
maybe
more
the
difficult, right?
yeah.
All right, thank you. And actually, there's a question on probiotics. Just give me a second. I had it, but I kind of lost it. So I just need to find it once more because we are kind of on this topic. So it's good to have a look at this now. Yeah, when should you start taking probiotics? Should I start it now and keep taking it and stop if I have a positive pregnancy, or stop after embryo transfer?
Again, no clear answer to that. Depending on how you take the probiotics. So we know that the main lactobacillus should be the Lactobacillus crispatus, which is the one that is the most friendly to colonize both vagina and most likely the uterine cavity. But if you want the probiotics to work properly, you should take them vaginally. Because if you take the oral probiotics, most likely most of the lactobacilli will be killed when they pass through the gut. So you might use the combination; it might work. So what we usually suggest to patients prior the embryo transfer to do, let's say, 10 days round of probiotics after they finish their menstrual bleeding for the embryo transfer, basically.
Okay.
But you can still take the probiotics even if you're pregnant. It's safe.
Of course. Thank you. Thank you for clarifying this as well. Catherine would like to also ask, do you have a detailed checklist on testing if my body is ready, especially for age 43? With all kinds of tests, I guess, right?
Well, we would start with, it depends on if you want to go for an IVF with your own oocytes or if you want to go for the egg donation. If you're speaking of the IVF, of course, we would do the hormone profile, do the ultrasound. This is usually sufficient, including, of course, the semen analysis, because we want to see the male factor as well. I don't think that doing, let's say, the preventive tests is worth it, because someone wants to sort of to cover all the possible aspects, but the thing with the IVF is that just by repeating the embryo transfers, most of the patients do get pregnant if the quality of the embryos is fine. And it's really a small percentage of women that do actually have some added problem or some other issues, such as, for example, the immunological factors and things like that. So the thing is, if you have too much data, you have to be able to interpret those. So I would just start from the basic examination to see if anatomically everything is fine. This can be covered just plainly by doing the two-dimensional 3D ultrasound, because since the ultrasounds are quite accurate, we can rule out most of the pathologies. Of course, after the age of 40, we might expect fibroids, polyps, and things like that. So these have to be ruled out first. If you want to try the IVF, then look at the ovarian capacity. But we have to keep in mind the age. We know that we need more eggs and more embryos to be successful.
I believe it was helpful for you as well. Thank you so much. And there are two questions on probiotics, so let's have a look. So which vaginal probiotics do you recommend? That will show Miraxan Explore are now discontinued. So anything you can add here?
Well, it's always different brands on each market. So as I said, Lactobacillus crispatus should be part of it, but the probiotics have usually several lactobacilli within them. So each country has a different brand name of the probiotics.
All right, thank you so much. I guess that answers the second question now as well. Thank you. Okay, so do you recommend natural transfer or medicated transfer for advanced maternal age women? Yeah.
Well, if you always, if possible, the natural cycle is preferable, but we know that with the women aging, we are dealing with luteal phase insufficiency. So sometimes, if the cycles are too short, then it's difficult to carry out the natural cycle transfer, because when the first phase is too short, then the endometrium doesn't build up properly, or we may not be able to track the ovulation. But in women, generally in women with regular cycles, the natural cycle is always the best way.
Okay, crystal clear here as well. Thank you. Are you familiar with this kind of drug? I will show it to you. So just give me a second. Yeah. Do you know anything about the fertility drug? Do you see it? Which is supposed to increase the rate of implantation during IVF.
Yes, yes. I actually participated in the clinical trial a few years back on this medication. It didn't show any efficacy at all. Then the same clinical trial was recently sort of copied by the Chinese, who have bought this molecule to develop it, and they came up with the same results. So unfortunately,
Okay,
it
got it.
was proven twice that there is no efficacy.
Okay, thank you for the clarification then. Now we will go for the next question from Larissa. So is endometriosis a chronic inflammation for which you use antibiotic before a transfer or even stimulation?
Well, the endometriosis does have effect on most likely the immune system response. It is a sort of chronic inflammation state, but nothing that be treated by antibiotics. It's better to downregulate the endometriosis, which means to reduce the production of estrogens, either prior the IVF cycle, IVF stimulation, or prior the cryo-embryo transfers. But it also depends on the stage and if the endometriosis is active or not. Because if you have
Okay.
active lesions,
Right.
sometimes before doing surgery might also be helpful.
All right.
So
Thank
it's
you.
not the antibiotics don't have the place here.
Okay. Yeah. All right. Let me have a look. Okay. Catherine also would like to know. So since it is difficult to get a normal embryo for advanced maternal age women, right? Do you recommend to test everything to prepare for success? So this is PT here, so I believe maybe PGTA or something like
Yes,
that.
yes, that's also a tricky question depending on how many embryos we are getting from the cycle. I have to say to start with that I'm not like a huge PGTA fan, so that's I'm not really pushing the PGTA in all the cycles. So we have to have a good quality blastocyst in order to test it, because we want to make sure that the embryo will make it through the biopsy, then freezing and thawing process. So there are lots of I don't want to call it the damage, but there are lots of things that we are doing to the embryos in order to get the results from the genetic testing. So from my point of view, if the woman has sufficient level of AMH and she responds well to the stimulation and she's able to produce multiple blastocysts, then doing the PGTA testing will definitely shorten the time to the embryo transfer, because then we are transferring the healthy embryos. But on the other hand, if we, for example, obtaining the eggs with the natural cycle, the question is whether to test each embryo, or let's say to accumulate several embryos over several attempts and then test them. So it is the age factor that we have to keep in mind also, not only to get the embryos or obtain the embryos, but also for the pregnancy. So you don't want to spend 2 years gathering up the embryos and then get pregnant. So yeah.
Of course. Thank you so much indeed for that. Now we will go for the next one, I will show it to you once more. So after 4 IUIs and 4 IVF cycles, all cycles failed. We moved to donor eggs. The first transfer, we got a chemical. The second double embryo failed. We have every test and check. Everything is normal, seems normal. We are preparing to do our third transfer. Embryo glue will be tried. Any other thoughts? Or just keep trying?
Well, depends on what tests and checks you've run. I guess that you're speaking about the immunological testing. Even sometimes we do the hysteroscopy to see the environment of the uterus. The effect of, for example, the ERA testing is still questionable. I would just keep on trying. If everything comes back negative, then as I said, you might be the unlucky phenotype and just need the right embryo to settle in. And yeah, I know it's tiring and demanding, but yeah.
True. Thank you so much indeed for that. Do you have an opinion of efficacy of microbiome testing, such as EIP or D-score?
Well, as I said, we don't have most likely the full insight on the microbiome, so our knowledge is still limited on this subject. So we still need some more advancement in research to gather up more detailed data on to see.
Yeah, definitely more research is needed.
What is the right composition? Yeah.
Okay. There are many things like that, unfortunately, that we need to just wait for some more results, and that's the case. Okay. What are the age-related issues in transfer, given that I have normal embryos?
You mean like normal? I guess it's meant to be genetically normal embryos.
Yeah, I believe so.
We know that the aging process doesn't affect the uterus that much as it does affect the quality of the eggs, but still the whole body changes. And with the age, we know that the vascularity changes, and most likely it's also the anatomical issues that come into place with the aging process. So we see women having higher percentage of, for example, adenomyosis over the aging, with a higher percentage of fibroids and things like that. So there might be some, let's say, additional anatomical factors that also play a role in the implantation. So this is something that we have to keep in mind.
Makes sense,
and it's also about
as well.
Also about the endometrium, how it responds to the stimulation, because again we see that with the aging process women tend to be less receptive to the medication, and the growth of the endometrium is becoming more and more difficult.
Okay, thank you so much for that. Once more, I will show you. There are some details here, so let me show you this question. So I'm 35, my partner 38. I have endometriosis, adenomyosis. He has astenosis, teratospermia. With intent transfer and for ICSI, we only had 2 blastocysts with grade 1 BC and 1 CC. So if we get a blastocyst, does it even make sense at that age and with that diagnosis to do PGTA? Can't I expect that the embryos are mostly euploid with our ages, and that only the other diagnoses are the reason for recurrent recurrent implantation failure?
Yeah. Well, you only had 2 blastocysts, so I think that we're dealing with the endometriosis that is affecting the ovaries, because most likely with reduced ovarian capacity. The question is whether there are no other, for example, genetic factors that may play a role, because you're still quite young. I would definitely do the karyotyping of you as a couple, because I would look at the presence of the fragile eggs, for example, which might be also one of the causes for preterm ovarian insufficiency. So that would be something that I would start with. And given the quality of the blastocysts, you still might attempt a PGTA testing, but we know that statistically, both adenomyosis and endometriosis don't affect the quality in the terms of having higher aneuploidy rates. So the euploidy rate is equal to any healthy woman at your age. So still you're within the, let's say, quite favorable category in the terms of the chromosomal health of the embryo. So I wouldn't necessarily force into doing genetic testing. I would most focus on the endometriosis and the adenomyosis then.
Okay,
But
there are
as I
some
said,
follow-ups. Yeah, sorry.
I would definitely rule out any other genetic cause of the preterm ovarian insufficiency first.
I just want to follow up because Larsa actually added some information. So let me just see. So karyotype testing came up normal. AMH is at 3.6. But she's also have another question. Have you heard about OSARA operation for adenomyosis, which is located in various areas of the uterus?
Yeah.
What do you think about it? Would you recommend it, perhaps?
I don't know if you've tried any hormonal preparation first, because the OSADA surgery is quite demanding for both the surgeon and the patient. The thing with adenomyosis, especially when the adenomyosis is, let's say, spread throughout the myometrium, is that it only is a site reductive surgery, so it won't remove all, it will just remove the majority of the lesion, but still some lesions may be left inside. And basically this kind of surgery, the most important part is a reconstruction of the uterus, because you remove quite a big part of the uterine cavity and then you create flaps that you have to recreate and reconstruct the uterus. And after that, there is a risk of uterine rupture during pregnancy. So it does have lots of possible complications. So this is always, let's say, the last kind of treatment that we choose in patients. But there are surgeons that sort of are focused on doing both endometriosis and adenomyosis surgery. So if they are skilled enough, they'll be able to carry out the operation properly.
Okay, thank you. And one more from the same patient. Okay, so what with endometriosis and adenomyosis, do you prefer a fresh transfer or a cryo transfer in the following month?
Well, especially in the cases of adenomyosis, I do frozen transfers, because with that, I use the combination of the downregulation that works on the central level with the combination of letrozole that inhibits the action of, let's say, the local production of estrogens within the myometrium. So this can be carried out during or prior the cryoembryo transfer. So that shows to have the best outcomes, but still not as optimistic and as in healthy patients, but it does give you better chances.
Okay, thank you so much for your advice here, Larissa. I hope that was helpful for you as well. Okay, Clara has a short question. I'm in the 2-week wait. Is there anything I should be doing to help implantation?
Just be optimistic. That's the only thing. There are a few things that you shouldn't do, and that is to be cautious about overheating the small pelvis. So don't go to sauna, don't go to jacuzzi. Other than that, you can behave normally, you can eat what you used to, and just keep positive, being positive. That's it. Yeah, you don't have to lie down and wait.
course, definitely. Sometimes it's better to
Yeah,
keep busy, I guess, as well.
exactly.
Not too
Yeah,
busy, obviously, but fingers crossed for sure. Okay, best of luck.
yeah. Good luck.
All right, thank you so much. And let me have a look. We will be slowly finishing, so if there are any other questions, you know what to do. This will be the final call for them. We still have quite a few of those. So let me just show you. So sorry, there's some information here from Rebecca. Okay, sorry. I have been recently diagnosed with RQ8 uterus. This is, I think, misspelled. I have a history of chemical pregnancies. Are my chances of successful implantation reduced?
By bit, yes. Again, any anatomical abnormality, but I would also look into some other possible factors as well. If
And perhaps, I will show you because there's some more information from Rebecca, so I think it's worth to have a look at this. I have had 2 chemical pregnancies before IVF. I had 3 medicated frozen embryo transfers, ended in big fat negative and chemical pregnancy. We used embryo glue. The first transfers, my progesterone was very low, so I think that could be the reason why it failed. Only my latest transfer with my progesterone was okay. What would you suggest we try different next time? Is it a case of just keep trying? I wanted to try immune protocol, but I had immune blood testing and clotting blood tests. All came back normal. It has recently been discovered I have a arcuate uterus and my ovary looks slightly polycystic. So on scan, or we could just have a genetic issue. I'm 36, my partner 39. We have male factor, morphology 2% low motility. Okay, and
yes, so
yeah,
your partner's
they
taking
had
some
hysteroscopy, laparoscopy, right? So this is the case here. Lots of information.
Yeah, well, I don't know, what do you mean by slightly polycystic ovaries? We know that the quality of the eggs within the women with polycystic ovaries usually a bit lower than if that correspond to age. It might also be the male factor that's contributing to the failures. So even the male factor itself is an indication for PGTA testing to the embryos, and combined with the maternal age, if there are several failures, then I would say that to test the embryos might be like the logical step to do. To see, I don't know if you mentioned that you had the karyotyping done, and then remember of the couple, because there might be some other contributing factors.
No information here on this.
No. You only mentioned the immune and the blood clotting. If we have the failures in the terms of, like, let's say, the repeated miscarriages, which might be your case because you had some biochemical pregnancies, then we are also looking for possible genetic causes that, but it has, so definitely the karyotyping of the couple would be like the next step to do.
Okay, thank you. Anything else, you know what to do. And let me just show you the next question. Okay. So what test would you recommend to a patient to do if the patient has had 2 failed cycles using own eggs and 3 failed cycles using a young egg donor? The eggs were untested, but they were transferred at blastocyst stage.
Well, since I guess that the three, if the 3 cycles means 3 transfers, then this is enough to say that, to suggest that those embryos from the young donor were most likely, most of them were euploid. So I don't know about the age of the patient that has undergone the IVF, so it might have been the age factor with their own eggs, and then, but when using the donor egg, you should have quite fair chance of having implantation with 3 attempts. I don't think that doing the PGTA testing to the embryos that come from the donated cycle is any helpful. Of course, we don't know about the other contributing factors. So again, you have to do a checklist to see all the possible aspects. So starting with the anatomy, starting with the semen analysis, other factors such as, for example, as I mentioned, the obesity, which is usually like left aside, but it's a huge contributing factor to the possible implantation failure. You can also do some basic immunological testing in the terms of the functional test of the NK cells, or even to perform a biopsy to see the activity of the NK cells within the womb. So there are lots of other tests that may be done. So basically, you just have to go one by one and see each individual patient to see what might be the most likely explanation.
Okay. Thank you so much. Lots of different questions, lots of details. And now we will go for, again, a detailed question. I think we can have a look at this. As you can see, there are two questions here with some information. So basically, the first question is, I'm afraid of taking steroids as it may affect the embryo, and thus my anti-TPO value is which is really high to take the steroids. Is that really needed? As you can see, the details here. This is the anti-TPO here, 126 units per millimeter.
Yeah, the question is if you're taking any like thyroid medication, since usually the antibodies are causing the chronic inflammation to the thyroid, which usually results in the hypofunction of the thyroid. So usually just by adding the thyroid medication, that might help with the antibodies, but this is your endocrinologist who is usually responsible for the treatment, so they have to take into consideration the whole thyroid panel to see what kind of treatment is appropriate. We are usually trying not to give the corticosteroids to the patient unless indicated. So, sorry, I just need to take a sip of water.
Sure. Take your time, of course.
So you might be in the unless indicated category. Giving the corticosteroids might have an adverse effect on mainly placental formation. So we see higher percentage of preeclampsia with patients on corticosteroids. So there might be some pregnancy-related complications. It most likely won't harm the embryo itself, but might affect the way that the placenta is formed. So let's say secondarily, it might affect the development of the embryo. But I would just leave this up to the endocrinologist to decide the treatment.
Okay, brilliant again. Thank you so much. And I believe now we will go for our final question. There are some questions left, but of course, we'll be happy to simply forward this to the team at GYNEM Clinic, and I'm sure they will be happy to get back with some details, of course, for you. As you can imagine, it could take a few hours to answer all of your questions, but I'm really happy that you are asking, and we are happy that I hope at least I believe it was helpful already. But the question that we would like to, sorry, I lost it again, but I have it, don't worry. Yeah, so this is the question. So is sperm likely to play a role in implantation failure even after ICSI was done and then embryos got to blastocyst stage?
Yes, as I mentioned, it might. There are some studies that show that, as I mentioned, the higher DNA fragmentation rate might have a negative impact on the implantation, but still we don't know what is the reason or what is the cause, let's say the pattern, or what exactly is happening to the embryo that will fail to implant when there's a lower semen quality. Usually, well, the ICSI method was developed to overcome the lower semen quality issues, so it's definitely a method of choice if you're dealing with lower quality semen samples. So it is the genetic information that the embryo takes from the father that plays a role to the way that the embryo is presented to the immune system. So we cannot leave the male out of it, but still we don't know how much it does affect the implantation failure.
Okay. Thank you so much. And as I mentioned, that was our final questions. As there are some questions left, but we would be happy to forward them, and then the team will get back to you with some answers for sure.
Yes.
Thank you so much, everyone. I do believe it was a very interesting session. Lots of different, various questions with lots of details as well. So, Dr. Kristýna, thank you so much for your time, for sure, and for sharing your expertise as well. Anything else? Any final words before we finish for today?
Well, I would like to thank you as well because it's really an interesting topic. And as I said, it's the implantation, you can imagine it as like a big puzzle that you have to put all the pieces together to make it work. So it may seem easy if you don't want to get pregnant, but in our patients, unfortunately, sometimes it requires a lot of patience and lots of time and also emotions and finances included, and it takes several failed attempts to get the baby in the end. And we know that this is our main goal of us professionals and the patients to have a healthy baby in the end. On the other hand, as I said, the failures are demanding, and sometimes people tend to turn towards, let's say, the sorcery and look for a magic cure or magic solution, but there is none. And just, follow our guidance. We are doing our best in order to get to the final point and to achieve not only the pregnancy, but for you to have the healthy baby back home and be happy with the treatment in the end.
Perfect. Thank you so much. Perfect ending for sure. Someone asked me to put the link to our YouTube channel. I just did that, so you can go to our YouTube channel, and this webinar, of course, will be available on our YouTube channel, but also on our website tomorrow morning. So you can subscribe to the YouTube channel. That way you will be notified that the video is ready. So thank you so much, everyone. I just want to add that we will be back, of course, with more events. And also I would like to invite you to take part in our Ask Your Doctor event that will take place on next Tuesday, actually, 7 p.m. London time. You can go to myivfnsus.com website and just simply sign up and then get with us live, and you will be able to ask more questions. Dr. Kristýna also had a chance to participate in Ask Your Doctor discussion, so I can assure you it's a great session. Lots of details that you can learn from fertility experts as well. So I can only invite you to join us, and of course we will be back with some more events. Thank you, everyone, for tonight. Lovely to see you again, Dr. Kristýna. And so, of course, we will have some more events with you coming up. So stay tuned. Take care and have a good evening, everyone. Thanks. Bye.
Thank you. Nice evening. Bye-bye.